Hi, my name is Darwish, professor and consultant of obstetrics and gynecology. Today, I would like to add to your experience and your practice a new indication of hysteroscopy in the office in your clinic when you are dealing with a case of abnormal bleeding with progestogen-only contraceptives. And this is actually a novel indication of hysteroscopy in the field of contraception. You know that progestogen-only contraceptives include different forms of synthetic progesterones used for contraception. In this short lecture, I'd like to address the progestogen-only contraceptives, the mechanism of action and role of hysteroscopy, abnormal bleeding and role of hysteroscopy and management plan, and again, role of hysteroscopy in this field. And this is actually a novel indication of hysteroscopy in this field. You know that progestogen-only contraceptives are increasingly used nowadays due to increased interest in long-acting reversible contraceptions due to the well-known advantages like use during breastfeeding and in cases of contraindication to estrogens, which are well known by you. And in a chronological manner, the generation of progestogens start by first generation until fourth generation. In the field of progestogen-only contraceptives, we are interested in the first generation, norethindrone acetate and hydroxyprogesterone acetate, second generation, which is levonorgestrel, third generation, desogestrel and etonorgestrel, and fourth generation, drospirenone. But from the biochemical or pharmaceutical point of view, the progestins or progestogens are classified into derivatives from the testosterone. Most of the progestogen-only contraceptives are derivative from testosterone, particularly desogestrel group or norethindrone acetate, or from progesterone, which is only medroxyprogesterone acetate, or spironolactone derivative, which is drospirenone, okay? So this is a short summary of the progestogen-only contraceptives. Derivative from desogestrel is Cerazid 75 micro. Levonorgestrel is derived from also desogestrel group and is 30 microgram, and norethindrone 350 micro derived from norethindrone, and drospirenone derived from spironolactone, and lastly medroxyprogesterone acetate from first generation. If we are talking about progestogen-only pills, we have norethindrone acetate 350 micro, the desogestrel 75 micro, and levonorgestrel 30 micrograms. And all these are used in different parts of the world. But recently, the introduction of high progesterone-only pills derived from the spironolactone, drospirenone 400 microgram, which is FDA approved, has been introduced in practice, and it shows some advantages over the conventional or commercially available POPs because of its long duration of action. So if the patient has a missed period, a missed use or more than less than 24 hours, no problem, but others should be used within 3 hours of the time of use. And it actually induces in the ovulation inhibition in most of cases, but the other POPs have less instance of inhibition of ovulation. So the high POP actually expresses good control of menstruation, as it is used for 28 days, 4 days placebo, so has normal withdrawal bleeding, so no bleeding episodes, but the other types have excessive bleeding. Also, in this group, we have etonorgestrel, which is subdermal implants in milligram, not microgram, 68 milligram, put in the subcutaneous in the arm, left arm. And also we have Mirena, which is 52 milligram levonorgestrel used in the uterus with efficacy of up to 8 years for contraception, as recently published by FDA. Lastly, medroxyprogesterone acetate, which is 150 milligram used for every 3 months intramuscular, and is first generation, which is progesterone derivative. These are the progestogens in a short. Now, the contraceptive activity of these synthetic progestogens actually is variable according to the type, according to the dose, and according to the duration of use. But generally speaking, they may have anti-gonadotropic action, which is causing inhibition of ovulation, and this can be detected by transvaginal sonography and hormonal assay, change in the cervical mucus, particularly POP, and this can be detected by simple speculum examination or hysteroscopy, and decent coronization of the endometrial picture necessary for implantation, which also can be detected by transvaginal sonography, endometrial sampling, or hysteroscopy. But there are some other variations due to the dose. As I told you, the type of progestogens. Some progestogens lead to progressive decrease in endometrial thickness in relation to the type and duration and dose. Endometrial thinning, for example, with POP, with scanty and atrophic glands are very much reduced since this is all progesterone receptors in these cases. And this has been recently reviewed by some authors. I also don't forget to mention the effect of progestogens on the fallopian tube. It has been in an animal study found to decrease epithelial ciliary motility, decrease muscle contractility in an in vitro study, but no human in vivo studies so far. Now we would like to assess the endometrial change with POP. This can be done by hysteroscopy. We can use it to assess the thickness of the endometrium subjectively. When you go with office hysteroscopy, you have a general look on the endometrium. Is it thin, thick, or normal? And also you can do a simple hysteroscopic endometrial thickness test by pressing on the telescope on the posterior wall from the fundus till the cervix. And if you notice a furrow, this furrow, if it is deep, this means endometrial hyperplasia. If it is not formed, this is thin endometrium. If it is formed but mild, this is considered normal endometrium. And this is also a simple test by hysteroscopy. During hysteroscopy, you should look to the vasculature of the endometrium. Is it normal, congested, petechiae, ecchymosis, bleeding on touch, or suspicious blood vessels, color, pale, pink, reddish, or dark red. And also if you find any lesions like polyp or so, you can see and comment during hysteroscopic assessment of cases with progestogen methods. If you compare hysteroscopy to transvaginal sonography, you will find similar findings. For example, normal endometrium appears from 8 to 11 millimeter by transvaginal, and in hysteroscopy, you can see it moderately developed gland openings in the endometrium with uniform distribution of blood vessels among healthy endometrium. If it is thin endometrium, less than 7 millimeter by ultrasound, narrow glandular openings, thin blood vessels, and distributed in a fragile endometrium. Thick endometrium up to 16, excluding the secretory phase, of course. And this can be seen by hysteroscopy as diffusely increased thickness in the prominent gland openings. Endometrial hyperplasia, echogenic diffuse small thickening of the endometrium, sometimes with hypoechogenic shadows, dots in cases of cystic endometrial hyperplasia. And this can be seen by local or diffuse endometrial thickening with papillary or polypoidal appearance with positive furrow test, as I told you. Regarding vasculature, the previous was thickness of the endometrium. Now, vasculature of the endometrium. In most cases, if you see normal vasculature as curved blood vessels uniformly distributed. This is normal, but sometimes it is hyperemic and hemorrhagic spots or BTK, sometimes congested with bleeding on touch, as seen on these photos. And sometimes atrophic endometrium is seen with scanty blood vessels, starry sky appearance, or strawberry appearance, which is due to gland openings prominence among congested endometrium, and this can be a part of secretory endometrium, can be a part of adenomyosis if you find other hysteroscopic findings of adenomyosis, or can be a part of inflammation. And lastly, you can see suspicious blood vessels. And these are some publications on the impaired inflammatory status of the endometrium with strawberry appearance with hyperemia and thickening. And these are some studies on abnormal vasculature of the endometrium, and has been mentioned to be dystrophy with scanty publications on this topic. Now, what about the fallopian tubes? We need to assess the effect of progestogen-only methods for on the fallopian tube. This can be done by an study mentioned by some radiologists to have repeated HSG to test the functional proximal fallopian tube occlusion in women using deep-hydroxyprogesterone acetate. They expose their patients to successive HSG, and actually this is unethical and leads to repeated pain, repeated irradiation, and invasiveness. Actually, it is not a practical way to assess the effect of progestogen-only contraceptives on the fallopian tube. What's new in this field is this is the target of this lecture, is to highlight the importance of hysteroscopy. In this short movie, you can look to the corneal ends and you can see the from the uterus, the fallopian tube as a ring, outer ring, which is the ostium, as an end of endometrium, and the beginning of the fallopian tube. And the conversion goals of this cone, which are intramural part of fallopian tube, and the summit is a dark spot. And this is called Darwish hysteroscopic triad and has been published as a missed anatomic landmark. If you focus on this point, you can see some peristalsis, which as contractions and relaxation of this Darwish triad as a documentation of functional activity of the proximal part of the fallopian tube. And this actually can be seen in normal ostium and sometimes in some ostia with polyps. This case has an intratubal polyp, and with peristalsis, as you can see, with normal peristalsis, fallopian tube, this polyp has been extruded from the intra-tubal part to become endometrial polyp. So this is not an uterine lesion, this is a fallopian tube lesion. And thanks to hysteroscopic detection, look to contraction now, and then extrusion of the fallopian tube coming out from this fallopian tube to the endometrial cavity, and to highlight the importance of hysteroscopy for detection of the functional status of the fallopian tube. Also, you can see entrance of air bubbles into the fallopian tube, which is positive bubble flow test in this case. And here the bubbles cannot come to the fallopian tube due to the effect of progestogen-only contraceptives. So this, the left side was normal, and this is negative bubble flow test as documented in some cases of progestogen-only contraceptives. These are the novel indications of hysteroscopy in the field of progestogen-only contraceptives. Look to negative bubble flow test. In this case, the bubbles cannot cross to the fallopian tube due to defective function of the fallopian tube. So hysteroscopy could signify the importance of effect of progestogens on the fallopian tube in vivo without any exposure to irradiation, without any invasive procedures. This is office procedure done without anesthesia, 2.6 millimeter periscope and 3.2 outer sheath. So this is negative bubble flow test in a case, And this is another case of negative bubble flow test, but this negative test is due to anatomic cause, which is polyp occluding the ostium. And this actually was not a case in our study, but to demonstrate the negative can be physiologic and can be anatomic due to a polyp inside the ostium or the Darwish triad. Now the combination of air bubble test and peristalsis together is called Darwishoscope test, and this is testing the anatomic and physiologic function of the proximal part of the fallopian tube. And here you can see the air bubbles and going to the ostium with post-peristalsis on both sides. And this is a case is not affected by the effect of progesterone. And air bubbles go to the ostium with peristalsis. You look to find contractions and relaxation of the ostium. Actually, we made a study on the cases with progestogen-only contraceptives and found that peristalsis and bubble tests and combination, which is Darwishoscope test, all of these are affected in the study group of progestogen-only contraceptives. So the unique advantage of using hysteroscopy to assess fallopian tube in progestogen-only contraceptives is that it can detect the fallopian tube functions and anatomic function and physiologic function of the fallopian tube, and both are affected by progestogens with negative bubble flow test, signifying that the tubal passage of bubbles is not a passive phenomena rather than being mastered by peristalsis, which is controlled by the hormones. And regarding the cervical canal, most of cases of POP are associated with thick endometrial, thick cervical mucus, and this can be easily proved by introducing the office hysteroscopy to the cervical canal to see the arbor vitae and the mucus plug inside, which is one of the mechanisms of action. So these are the uses of hysteroscopy to document the mechanisms of action on the endometrium, on the fallopian tube, and on the cervical canal. So three of the mechanisms of the progestogen-only contraceptives can be easily detected and proved by hysteroscopy in no time. Now we go to the second part of the talk, which is abnormal uterine bleeding with progestogen-only contraceptives. As you know, the FIGO classification palm coin. Palm is structural and coin is functional causes of abnormal uterine bleeding. Regarding the functional, we have ovarian dysfunction, endometrial causes, iatrogenic causes. The three causes are seen in cases using progestogen-only contraceptives: iatrogenic, effect on the endometrium, and effect on the ovulation. And in cases of progestogen-only contraceptives, you will find a paradox, which is thin endometrium, atrophic endometrium, but bleeding, excessive bleeding, and bleeding episodes. How to occur thin endometrium with bleeding? How to explain this? This can be due to superficial blood vessel fragility, as mentioned by some authors. A common feature of all progestogen-only contraceptives is the effect on the vasculature in addition to the thinning. So the thickness is okay, thin endometrium, atrophic endometrium. But what about vasculature? All of them affect vasculature, underdeveloped spiral arterioles, dilated thin wall vessels, and this may be the cause of abnormal bleeding with progestogen-only contraceptives. Other studies found that there are apparent vascular transformation that are causing the abnormal bleeding with progestogen-only contraceptives by inhibiting vascular smooth muscle cells, leading to disruption of the blood vessels, as proved in some studies. So we have a paradox of thin endometrium and abnormal bleeding with progestogen-only contraceptives. How to diagnose a case? We have to exclude palm, organic causes, and this can be done by transvaginal sonography, endometrial sampling, and also hysteroscopy. Hysteroscopy is superior to transvaginal. Of course, transvaginal ultrasound is the first line for screening of your patient, but sometimes it looks normal, but hysteroscopy can show some findings because hysteroscopy is the gold standard. It can see some tiny lesions like tiny micro polypi that cannot be easily seen by transvaginal sonography, even three-dimensional. And it can show abnormal vasculature, which is not seen even by three-dimensional, in addition to assessment of the fallopian tube functions. In our study, the results of hysteroscopy and transvaginal sonography were more or less similar and complementary. Regarding comparison between hysteroscopy and endometrial sampling, hysteroscopy is superior to endometrial sampling. Of course, endometrial sampling is the gold standard, but it is an invasive procedure. These patients are young patients usually. They don't have some abnormal cells, but bleeding is caused by a drug which is used by the because of progestogens. The hysteroscopy gives information about the endometrium, accurate assessment of vasculature and non-vascular structures that can be missed by endometrial sampling, and minimize the burden of a pathologist by eliminating unnecessary sampling, stress of the patient by waiting for the result of biopsy, and these are disadvantages of endometrial sampling. How to treat abnormal bleeding with LARC or progestogen-only contraceptives, different lines of treatment, including COCs, assurance, norethindrone acetate doxymycin or doxycycline. Others use non-steroidal anti-inflammatory tranexamic acids. Others use adding norethindrone acetate 5 milligram to POP to control bleeding, because norethindrone has been proved to be converted in part in the liver to ethinyl estradiol, which is a good option for bleeding control in patients with low estrogen levels who are progestogen-only contraceptive users. And these are the mechanisms of action and how to diagnose the cases of abnormal uterine bleeding and role of hysteroscopy. So in conclusion, I would like to say that hysteroscopic documentation of mechanisms of action of progestogen-only contraceptives is feasible because it can have in vivo observation of the whole endometrial cavity, endometrial thickening, endometrial vasculature, and vasculature is very important. Vessel is so important, vessel morphology and distribution, accurate in vivo assessment of the fallopian tube functions, and lastly, it can offer easy detection of viscid cervical mucus. So it can assess the mechanism on the cervix, endometrium, thickening, vasculature, lesion, tiny lesions, and also fallopian tubes. As I told you, adding hysteroscopy to the diagnostic workup of a case of normal bleeding with progestogen-only contraceptives is valuable and eliminates empiric lines of treatment. And lastly, in this algorithm, we designed this algorithm to highlight the importance of hysteroscopy in the management plan of abnormal uterine bleeding in progestogen-only contraceptives. Regular users, if the patient is irregular user, she is not in this algorithm. Regular users, we have to do, of course, first line, which is transvaginal sonography, 2D or 3D. If you suspect endometrial polyp by 2D, you have to confirm by sonography. If it is confirmed, you have to do hysteroscopic polypectomy. But if it is 3D and you found polyp, go directly to hysteroscopic polypectomy. But no polyp, you have to offer the patient office hysteroscopy. If you see by transvaginal sonography free endometrial cavity, free adnexa, hysteroscopy. If you see by ultrasound ovarian cysts, it should be managed by COCs. If no cysts, go to hysteroscopy. If the lastly patient is wearing levonorgestrel IUD, IUS intrauterine system, and it is displaced or malrotated, should be extracted. If it is well placed, go to hysteroscopy. So the hysteroscopy has a central role of cases of using progesterone-only contraceptives, and cases of levonorgestrel, it has indication ovarian cysts, free cavity, or endometrial polyp, non-seen. And hysteroscopy is done to assess the thickness, as I told you, the fallopian tubes, the color, and vasculature. Regarding the vasculature, if it is abnormal vasculature, you can give tranexamic acid, diazepam, or non-steroidal anti-inflammatory. But if it is normal vasculature, normal thickening, normal color, no lesion, so hysteroscopy confirms that there is no local cause. In such a case, you have to accuse systemic cause for this bleeding, and you have to give norethindrone acetate as proved by many studies to be converted to ethinyl estradiol in the liver, or COCs or estrogens. So the hysteroscopy has a central role in the management plan of cases of abnormal bleeding with progestogen-only contraceptives. And by this way, this is a new indication of hysteroscopy in modern practice.